So this is part two of referral criteria for CT and MRI. So just following on from part one, so skeletal mets, MRI is more sensitive and specific than CT potentially would be, especially for marrow-based lesions. But again, thinking about that field of view, that specific field of view that you're requesting within your MRI scan. Any osteoporotic collapse, thinking about you using MRI scan for distinguishing between old and recent fractures, and helps exclude any pathological fractures that you may be suspicious of. Any soft tissue lumps less than 5 centimetres that are stable, soft, mobile, non-tender, they don't routinely need an ultrasound scan. However, if you're suspicious of them, then you can use ultrasound to be able to visualise these in a little bit more detail. And some of you may actually be qualified to use an ultrasound scanner or feel confident to do so. So PVNS, so pigmented villonodular synovitis, is where the synovium thickens and grows. The mass that forms from this is not cancerous and doesn't metastasise, but if you're suspicious of this, you'll be looking more towards the MRI side of things, sorry. So thinking about other aspects or other conditions that you may come across and which to lead more towards. So synovitis, you'd be looking at MRI scan. Osteoarthritis, always X-ray, cheaper, quicker to do. Myeloma, follow-up MRI scan, limited to the spine and the pelvis. Spine, new vertebral osteoporotic or pathological fractures, again looking towards MRI. Any plantar fasciitis, normally we wouldn't be managing them with imaging, because again, is that going to affect our management plan for them? And I would always suspect going down towards ultrasound scan way before MRI scan, because all it's going to tell us is that something's irritated, and we already know that because it's painful for the patient. So thinking about conservative management before we start imaging. MRI more sensitive to fractures, so suspicion of fractures, pathological, traumatic. Again, we're thinking towards MRI scan. Osteomyelitis. So if we're suspicious of osteomyelitis, you can look at fat suppressed MRI scans, or CT can demonstrate where you would need to be doing a biopsy from. So with osteomyelitis, it's always worth having a chat with colleagues. You would always be referring to orthopedics anyway, if you were suspicious of this. So it's always worth a conversation with your radiology colleagues and having that relationship with them where you can back them backwards and forwards. Now, so that's all I need to talk to you about from a referral point of view. So from here, what it might be worth doing is just pausing, taking 15 minutes, 20 minutes, and have a go at producing your own guidelines or flowchart for where you might send patients to, or where you might send them, or what pathway you might put them on. And also setting up meetings and conversations within your clinical environment with your radiology colleagues, so that you can discuss openly about referrals. I think it's always worth bearing in mind within primary care, having those sessions. So we used to have X-ray meetings whereby we could bring specific patients to the forefront, and we could discuss them with a radiologist present, with a consultant present, with GPs present. So these are all options that are really useful, and things like the virtual fracture clinics work really well. So you don't all have to be sat in a room, it can be done remotely. So thinking about software like Zoom, like Skype, where you can all come together virtually, bring up images on your desktop that you've requested, or bring case studies to the arena and having a chat around those. That's always really useful. I think in terms of texts to back things up, one of the major texts that I really like to use is the Essential Musculoskeletal MRI, a primer for the clinician, which is by Michelle Weatherly and Martin Young. That's a really nice MRI textbook. You can also get radiographic image analysis. You can get a workbook, and you can also get the textbook itself. That's by Kathy McQuillan Martinson and Stephanie Harris. Now they're really nice for sort of going through in a bit more depth image analysis. If you wanted to broaden your horizons a little bit. In terms of programs online, there is one that Helen, who's a radiographer, whose presentations these are, likes to use, and she uses the iRefer, which is part of the Royal College of Radiologists. And for a year, that costs £90 for one login. But for 5 users, it's £360 for the year. Now, that might be worth thinking about in terms of a business case towards your managers for the trust itself. So you can have the login, pay the £360 a year, and within that, that gives you pathways and musculoskeletal case studies to work through that might be quite beneficial within your clinical areas. I know when I've used it previously within clinical area in Leeds, that actually it's quite a useful tool to have in your toolkit.